Cast is now starting. All attendees are in listen-only mode.
Good evening, everyone. I hope you're all doing well. Thanks for joining us today. We're going to talk about the real reason dentists fail at dental sleep medicine. And as everyone on this session knows, dental sleep is rife with obstacles, with hurdles, including medical billing, side effects, working with physicians. There's a bunch of them. And what we're going to do today is we're really going to try to not focus so much on those symptoms that are inherent to dental sleep, those obstacles, but really get down to a root cause analysis. So, Dr. Elliott, can you give me an example maybe where you've used a root cause analysis, this process with a patient?
Well, for example, today I had a patient come in with a broken distal buccal cusp on number 18. So the simple solution would be to just do the crown and get your production for the day. But instead, we actually had a conversation about why his tooth broke and the bruxing that he also had. And so he went home with a sleep test today. It's interesting how when you are looking for that root cause, then all of a sudden your eyes are open. You can't look at your patients the same way.
Well, why didn't you just repair the tooth or make them a bite splint?
That would be typical dental thinking.
Gotcha. So that's what we're going to do today. We're really going to focus on getting to the issue behind the issues, and hopefully help some of you on here learn and grow and help more patients. So why are we here to talk to you? Many of you don't know me, which is understandable. My name is Jason Tierney. I'm the COO for DS3. I'm the editor-in-chief of Dental Sleep Medicine Insider, and I've really kind of been immersed in dental sleep and TMD for over 10 years. And so I'm oftentimes in the background. Fortunately, I've got some of my colleagues, Jody and some others today, helping us out with answering some of the questions in the background. So please type those in over there in your bar to the right. Type those in, and Dr. Elliott and I will try to get to all of them. And also, if you've got any book suggestions, as it says here, I really enjoy reading, so if you can give me some book suggestions, I'd appreciate it. And with that said, I'll hand it over to someone that really requires no introduction, Dr. Elliott. Who are you?
Who am I? I didn't realize. So I am
an existential question.
Dr. Erin E. Elliott, actually. My middle name is Elizabeth, so had been called Triple E in the past, but I prefer E cubed because it's nerdier. But I am a typical general dentist in Post Falls, Idaho. I've been at it 15 years now. I added sleep into my practice in 2009. And as you can see, we just have continued to expand and grow because I also get to manage the right side of that. We have a large team with 3 doctors, and it's a lot of fun. And I'm going to be sharing more with you in the upcoming slides. So leave it at that.
So before we get rolling with that, just a couple of housekeeping things. If you remain on until the end, we'll really try to be mindful of your time, and we'll wrap up right at the hour, answer some questions afterwards, try to get through most of them, or to most of them, during the session. But your CE certificate will be emailed to you in the next 24 hours, so please keep an eye out for that. If you don't receive it, check your spam. Sometimes we get relegated to spam, but that'll be there. And then also with that email will be a link to register for our next webinar. Dr. Yatros and Dr. Drake will host how to treat 99% of your patients with these devices. So I ask you to keep an eye out for that email. Be sure to tune in to that webinar when they'll really focus on which devices they use when, and when each of those are indicated and contraindicated. And speaking of Dr. Yatros and Dr. Drake, they're both taking a break tonight. So while they're taking a break, Dr. Elliott and I, E3, E cubed, we're going to have a good time, and we're going to play Dental Sleep Medicine Obstacle Jeopardy. I will be filling in for the dapper Alex Trebek, and we'll be covering these categories. So, number one, who needs it? I love medical billing said no one ever. The medical community thinks I'm invisible. Give me bite changes or give me death. And lastly, I don't know what I don't know. So Dr. Elliott, what category would you like to choose?
All good topics and all the excuses that I have heard in the past. I'm going to start simple here. Let's go with who needs it for $100.
All right, who needs it for $100? And the clue is, so I'm trying to operate several things here. I don't have any sleep patients.
The question is, what is BS?
So thanks for being for keeping it G-rated here. But when you talk about not having enough patients being BS, why is that?
Well, I have to be honest. I am in a small town, so you do kind of wonder, will you have enough patients? There's my nice little waiting room. Again, we do a lot of bread and butter dentistry, nothing fancy. Fortunately, that population is going to continue to grow because it is a beautiful place to live. But as you can see, I have Post Falls Family Dental and Sleep Better Northwest. That's how many patients we have. Now, as Jason showed you in that graphic earlier, 1 in 5 patients have sleep apnea, and up to 80 to 90% remain undiagnosed. And as the demographic gets older, 50% of the population over the age of 50 has sleep apnea. And if these people are going around undiagnosed, treated with medicine for medical conditions that can be led or can have the root cause of sleep apnea, you can only imagine how many patients you have within your 4 walls. Now, for example, my practice is pretty busy and big, but let's just say you have 20 patients that come in your door each and every day. That means that there is at least 4 patients every day that come in your practice that has sleep apnea. And not all of them are diagnosed. And of those that are diagnosed, that actually admitted they had a problem and actually went to go get diagnosed and tried the therapy, how many are actually using the therapy that was given to them? In addition, all those CPAP wearers, I don't try to take CPAP away from them, but there's many mild to moderates that are wearing CPAP because they weren't given another choice. I cannot tell you, you can probably hear the passion in my voice, how many patients there are that are suffering. And we as dentists are on the front lines to help them. And at the very least, you need to get educated just so you can help these people, and they will thank you. They won't just be patients, they'll become raving fans.
Yeah, and just to be sure that I'm clear, because I've heard from some dentists in the past that have said that dental sleep might be something that patients need in kind of a top tier, large, densely populated metropolitan area. If I'm looking at these stats right, you've got south of somewhere around 28,000 citizens. And you're doing a lot of dental sleep. You're helping a lot of patients. So what's one last piece of advice that you might give to a dentist in a smaller market that says that they just don't have the patience?
Well, first I tell them that's BS. The second is I almost think we have it easier in a smaller town, in a smaller population, because I can bridge and forge relationships with the community, not just physicians, but I can be out there and, you know, I'm kind of that person to go to, because I think it helps that I'm outgoing and passionate about it. But I had a person come up to me and say, hey, I'm supposed to talk to you. And I was like, oh, okay. And he's like, I was told I snore, and then they said to talk to you. So what do? I don't even know what you do. Now, if that's not branding, that's, I don't know what is, but that's also helpful, beneficial being in a smaller town.
So
Once I get to the 28,000 people, then they have dogs I can treat, right? I won't run out of
Sure.
patients, I'll tell you that.
Sure. Cool. Well, let's move to the next category. What would you pick, E Cubed?
Well, I'm pretty linear though, so I'm just gonna go with the next category. I love medical billing, said no one ever, for $100.
For $100. Insurance doesn't pay for oral appliance therapy.
What is BS? Okay, or what is a commonly held falsehood?
Sure. We can go with BS. I was trying to be a little more PC than I guess you were today.
Yeah.
But I mean, I hear it all the time, you know, over the past 10, 12 years, and it's certainly changed, I believe, in that time. But I hear from dentists that, you know, they maybe tried to bill themselves for a patient and weren't successful. So essentially, they walk away from that and they say, you know, medical doesn't pay for these. It's not profitable. It's just a big pain. What would you say to that?
I would say that I look at it as a challenge. I would say that medical billing is different than dental billing. Like, we do a DO on number 12, we send it in, they may downgrade to their amalgam fee, and the patient owes this much. And we can tell the patient almost to the dime what it's gonna be. But even dental insurance now is getting tricky and playing games. And so, you know, medical billing, I would say that as a dental community in billing medical, that oral appliances and the things we do it is one of the easiest things to bill to insurance. And for the we get claims paid each and every day. There wouldn't be anybody doing this if claims didn't get paid. But there is a learning curve, and you just have to be dedicated to it. You will get through it. You will get the hang of it. It's just new. It's different. But medical insurance, it's pretty straightforward. And, you know, sometimes I get, you know, there's different third-party billers out there, and I even utilize them. And I'll get an office say, so-and-so is not doing a good job, and so-and-so didn't do a good job. Who should I use next? And that's where I'm like, you know, I think there's a common denominator here. It's maybe not the billing company, maybe it's you. Are you providing the proper documentation? Are you providing the proper communication? It's not like you just write number 12 DO, decay, that's it. You need soap notes. You need documentation that this patient does in fact need an appliance, and we have to prove it to medical. Once you get a system and a flow, it's pretty straightforward from there. I do have to say, I love this graphic because it says August 14th. That's my birthday. So I didn't know if you were just putting that in there subtly for me.
That's exactly why I. And actually, speaking of, I think you shared earlier that tomorrow is your 20th wedding anniversary. So
crazy, right?
Happy anniversary.
Thank you.
Yes, and I'll be sure to mark in my calendar that August 14th is your birthday. And I'll be sure to mark that, I mean I will forget that by the next slide.
That's okay. It's just another day.
So what's you said you're linear. So the medical community thinks you're invisible for 100. No physicians will refer to me.
I'm going to say, so what are you going to do about it?
Yeah, and I think another acceptable answer would have been, what is BS?
BS.
Yeah. Yeah. So, I mean, you've done, I know from being friends for so many years, that you work with a lot of physicians. You mentioned earlier that you've kind of become one of the go-tos, if you will, in your small community. So, can you just talk a little bit about what you've done, or what you've seen other dentists not do that have maybe separated them from you?
Well, I do think it's fascinating. As a dentist, I don't think like a typical dentist, I don't think. And what I mean by that is dentists like to think of all the what ifs, the one-offs, the things that don't ever happen that they think happen every single time. And maybe they had a physician say, oh, appliances don't work. And so they said, well, no one's going to refer to me. But just like we said earlier, you have so many patients within your four walls. You need to earn the right to go to physicians. And you better believe that sleep physicians have been hit up all across the US. But there's so many other physicians that are down in the trenches with these patients besides sleep physicians. Sleep physicians see the people that have already admitted they might have a problem and they're directed to them. They have patients that are kind of maybe already accepted that. We are starting with a lot of times people that have never even heard of sleep apnea, yet we see the signs and symptoms. We can work with physicians, like I said, each and every day, primary care physicians, endocrinologists, cardiologists, psychiatrists dealing with people that have anxiety and depression. So all of those health consequences of untreated sleep apnea all have specialists. And these are physicians that I think focus on the one thing but don't look at the big picture, and that's the advantage we have as dentists. So again, I get out there and educate. I hit the pavement, but I treated my team members, I treated their spouses, I treated my family, I treated patients that were struggling with their CPAP. Start with the low-hanging fruit. And those are people that have tried, that been diagnosed, accepted they had a problem. They were tired enough to go get a diagnosis, tired enough to give the treatment given to them, and really tried and are still looking for a solution. That's the easiest place to start because they want help. And then go to the physicians. Now, I utilized relationships that I already had with some. They were my friends. I've gotten the opportunity to speak at the local hospital at the grand rounds. I bring lunches, I bring coffee. I talk to them out on the soccer field.
And all of this just fell in your lap, though, right?
No, I hit the pavement. We all have days off. And I think it's funny, I said to a patient today, how I buy all my clothes online. I was like, I don't have time to shop. And I said, wait, let me rephrase that. We all have time for things that are important to us.
Sure.
It's just that shopping's not important to me. But
yeah,
on the day off,
I think with anything, E-cubed, show me how you spend your time, show me how you spend your money, and I'll be able to tell you what's important to you.
Exactly. And to me, treating sleep in my practice was important to me. And again, I laid the groundwork. I made plenty of mistakes, and that's why I love to teach, because I can almost fast forward many of the mistakes I made. And of course, this portion of our practice, dental sleep medicine, is changing constantly and evolving. And I feel like I can stay on top of that to help other people. But I started in my practice and hit the pavement. And so I just make it a no-brainer for physicians to refer to me. And that's how I present it to them. You can show them studies and papers and all of these things, but they don't care. They really don't. They want it. It comes down to, one, are you going to take care of the patient? And two, how much is it going to cost? And so if I can eliminate those things, I want to make it a no-brainer for the physician to just send the referral over to my office, to know that I am going to take care of that patient from beginning to end. I'm going to call them, I'm going to follow through, I'm going to send them letters along the way. And then if we do a follow-up sleep test and they're treated, I'm going to send that along. Like, I keep them in the loop so that it's like, oh, okay, you have a problem, I'm just going to send you over there. I don't have to worry about it. And then the second is if you let the physicians know that you will bill medical insurance on behalf of the patient, I do Medicare as well, then it's, like I said, just becomes habit for them to refer to me.
Sure. So you're creating that habit. You're making those introductions. You're making it simple. It's not unlike purchasing from Amazon in a sense, right?
Mm-hmm. Well, and one other thing I would say,
it becomes a habit.
I would say that I did earn those referrals, meaning that I didn't go to them saying, okay, here's my card, refer to me. Here's my card, refer to me. It was more like, hey, how can I help you with these patients? Or how can I refer patients that don't have a primary care? How can I get them to your office? What is the best way? And with sleep physicians, they are so busy that, yes, I did get in front of them and I've built great relationships with them, but I went and hung out with the techs. They're the ones that nerd out and they have the time. I loved going and just say, oh, that's a K complex. We're in, stage 2 or stage 2 sleep. So like that's another avenue of getting into the medical community. And they're not all standoffish. You will get some. You will get some grumpy old physicians that are jealous of dentists or tell you that appliances don't work. But guess what? There are other people, there are other physicians out there, nurse practitioners, PAs.
And I think it's important to remember too that, yes, you're likely to encounter some physicians like that. You're also likely to encounter somebody like that at the grocery store, right? We're people, right? We've got differing personalities and we have good days and we have bad days and I don't think that that's a fair reason to just write off an entire potentially life-saving treatment, right? And working with
right. Yeah. And you don't have to be the one to do it. Now, I will say that I enjoy it, but there's times where I'm traveling a lot. So we're going to get to that, how to utilize your team later on, but send someone that is, obviously polished and represents your office well.
Yeah, don't send me.
They can do the same thing. And when I go do a lunch and learn, I'm not disappointed when the physician doesn't show up. I'm not disappointed when they come for 2 seconds, grab a sandwich and leave. That's okay. Because I went and did a lunch and learn where all the nurses, of course, came. I showed them sample appliances. I kind of explained what I did. I had the science there. But like 3 of them came up to me afterwards. They're like, I've been sleeping in a separate room from my husband for the last 5 years. Maybe I should come see you. I'm like, yes, that is not normal. And so if you show this value of what you're doing to a staff member at a physician's office, guess who's talking to the patients the most?
Tell me.
That person. The nurses and the people, they're the ones that are spending the most time with patients. So by talking to them, by treating them, that's gotten me some great relationships as well.
Wonderful, wonderful. So next then, you've got give me bite changes or give me death for 100. It'll change their bite?
Yes, it will. So the question, or my answer is, would you rather be dead?
So there's a ton of different devices, right? And most of them protrude the mandible and in turn splint the airway. And side effects bite changes are a potential side effect, right?
Yes.
What do you say to the dentist? You lecture all over the country. You're talking to dentists all the time. What do you say to a dentist that cites this concern?
I say, and I said, you will change bites, get over it. Oxygen's way more important. In fact, I start out my lecture that way. I share a story about a patient who had a pretty significant bite change. And I freaked out. I sent her to the orthodontist. I was really upset that she was given this sleep appliance that changed her bite and actually caused an open contact. And that's why she saw me. She came to me because she was getting food stuck in her crown now and not because she had a bite change. But I had the problem with it. And there was one thing that I absolutely learned leaving dental school was that Class 1 canine guidance can cure cancer and plantar fasciitis, Jason Tierney.
Thanks.
Saying that, what the orthodontist sent back to me, and this is in 2008, really before I got trained and looked into it, he wrote back, no orthodontic treatment recommended at this time. And that's when it hit me. She's wearing her appliance. She does not want to live without it. She's never felt better. She sleeps great. And the best part about it is she didn't even know she had a bite change. It was me that had a problem. Now, I was golfing last night, and I will say I was on the phone, and it was my turn to drive, and my husband was upset with me because I was on the phone and I was supposed to be having fun. But I got a concerned phone call from a dentist, and this patient had an open bite on just the left side. And he's like, well, I'm going to do 5 crowns and or a bridge. I'm going to do, I want to do ortho. And I said, okay, then make sure she's on a CPAP. And he's like, oh, no, I was hoping that we could keep her in appliance the whole time because she won't go without it. And so finally I asked him, I was like, hey, who has the problem with the open bite? Is it you or her? And I feel a little bad about the way I said it, but it was kind of like he had to admit that it was him. Mm-hmm. And she actually, turns out, looking back at the picture, she had that open bite due to a previous jaw surgery and trauma. It wasn't the appliance.
Well, in E-cubed, there's research to support that CPAP changes bites, right?
Oh yeah, definitely. My cousin was like, his maxillary incisors had tipped so much that he was having issues with that. So, saying that, I think we need to get over it. However, we can try to minimize it, mitigate it. I'm a keep it simple kind of person. I don't live in a very litigious state, but I do go over that upside and all around, and I keep it simple though. This is kind of my conversation I have, is that the good news is there's not a whole lot of side effects to the appliance except feeling better, but it's not a pill and it's not surgery. And already right there the patients are like, yeah, you're right. And I say, but as your jaw's postured forward at night, not yanked forward, not ripped forward, sure. As your jaw is postured forward, the muscles are going to relax and adapt to that forward position. So in the morning when you wake up, your bite's going to feel a little bit off. I said, for me, when I wear one, and every single time they're like, you wear one? Oh my gosh, like I'm not alone. I say I chew gum for 5 minutes. For some people, it takes a little bit longer, but don't worry, we give you some exercises, we give you a little chew toy is what we call it, so that we can work those muscles and get it back to where your teeth fit back together again. I said it is rare, but it can happen that the bite doesn't fully come back. But don't worry, I don't make you look like a bulldog, because that's a concern for women, and no one's ever missed a meal. And almost every single time, my guys with little pot bellies pat their belly and say, oh, well, I could use that.
Yeah, sure.
And I say, no one ever misses a meal. It's just that your teeth don't fit perfectly together the way they used to. And the only people that really seem to care are dentists. So if your dentist mentions to you your bite's changed, you say, yep, I know, but guess what? I'm getting oxygen to my brain, so I'm all good.
Yeah.
If it is a concern, we can certainly address that. Just, do the things we tell you, and we'll try to minimize that possibility.
Sure. I remember being at a friend's office once, and a patient was there for recare with their device, and they didn't bring it. And it was Barry Glassman, and he asked, well, why didn't you bring your device? And she said, because I can feel that my bite has changed, and I was afraid that you would take it away from me. And she said, I don't want to give it up. I don't care about the bite change. And his point was really, sounds like, his retort to that really kind of mirrored yours, where it's just like, if you're happy with it, if life is good, who cares? Who cares about the bite change?
And, if, like I said, I always tell the patient when they come in, they say, my dentist said I needed to talk to you about this. I was like, okay, well, let's address it. You need to stop wearing it. We'll get you on CPAP. And they're like, oh God, no. And I'm like, okay, well, let's make, and most of the time they're not using the chew toy. It's because they're not in pain. And there's all these theories out there as to why the bite change happens, but it's usually not because of pain issues. It's almost like that's where the muscles are the happiest, so they're going to stay there.
Sure. Excellent. Well, let's jump back to our board with you still want to with I don't know what I don't know for 100. So I need to learn everything about everything first.
Such a dentist way to think. Jason, what I'm going to ask is, what else do you know everything about?
Well,
do we know everything about everything?
I know next to nothing about anything, but this is one of my favorites because, I have the benefit of, I've worked with thousands of dentists over the years when it comes to dental sleep. And the number of times that I've heard a dentist, or I've seen a dentist at dental sleep course after dental sleep course after dental sleep course all over the country. They've spent, a college tuition on dental sleep CE and haven't treated a patient. So, with that said, there is a ton of valuable CE relevant to dental sleep, specific to dental sleep around the country. We've got a few familiar faces. It's almost like a 7-person Mount Rushmore here of dental sleep. We've got Richard Drake, John Tucker, Guy Yatros, Jameson Spencer, Barry Glassman, Steve Carstensen, yourself, E-Cubed. There's a tremendous amount of invaluable education out there. So, what else do you say to those dentists that come to your course that you maybe have seen a couple of times at different meetings and they're not treating any more patients? What do you say to that person?
Honestly, one of my favorite mottos in life, or 2 mottos in life, is make it happen and figure it out. I think, again, they're just that paralysis by analysis. They're thinking of all the what ifs rather than just doing it. I will say that early in my teaching career, I try to make it as practical as possible, comprehensive. I just felt like I taught my heart out for those 2 days, giving away just like a cookbook, a step-by-step of everything that I learned. And it was all doctors in the audience. Only one person had a team member there. And I had this group up around me afterwards, and their questions were, what course should I take next? And I physically, literally just dropped my head with my head in my hands and just said, go back to your practice and just start. But I was in line at the symposium. I had just spoke this past February at the DS3 symposium. And I heard this these two dentists talking about the mini residency, and then they're going to go to this mini residency next, and da 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 da. They saw me in line. They're like, "Hey, thank you for what you shared. It was really inspirational." He's like, "How? I need to treat more patients. What should I do?" And I was just looking at them thinking, wow, they've got all this education and all these initials after their name, but very overeducated non producers of appliances. So what's the secret? What's the secret sauce? I think you're going to go into that a little bit more. But yes, education is really important, and good quality education, of course, based in science. But I think it's getting your team on board, and you just need to start treating patients. Stop overthinking it and start again. My biggest soapbox, of course, is to make sure they're tested first. Don't just start making snore guards and thinking that you're helping the patient and they're done with treatment. But other than that, like, just start helping people, and it'll catch on. Do you remember? Well, you don't remember, but there was a time when doing an occlusal amalgam was the scariest thing on earth. Now we could do it blindfolded. There was a time where placing your first crown was going to be the scariest moment, and now it's something we don't even think about. You have to get started.
It's kind of like riding a bike, right?
Sure.
So to that point about education, before we head into final Jeopardy, we're going to have a quick commercial break. So I mentioned Dr. Yatros and Dr. Drake. They present courses all over the country. We've got some upcoming dates in Long Island, St. Louis, Cleveland, and some others. Registrants for these courses get their own dental device. They get a sleep test. They get all the meals, 14 hours of CE. We deliver devices during the course, and we really focus on the practical aspects of the dental sleep workflow. So your own device, 14 hours of CE, step-by-step approach, your own, all of that's included. It's typically $995. If you type course right now, Jody or Brandy will get you registered and save you a couple $100. So just type course. There's a list of the courses there. We add new courses all the time. So type course. They'll circle back with you tomorrow and get you registered so that you can come and see how this works in person. And then Dr. Elliott, you've got, I feel like every time I turn around, you're on a podium somewhere teaching the masses.
No, I walk amongst them when I speak. Yes, I have partnered up with Tarun Agrawal.
T-Bone.
And so we have courses, actually a West Coast date now, but kind of the headquarters in Raleigh. Big misnomer. His teaching center is called 3D Dentist. You do not need to own 3D in order to come. So it's basically a sleep apnea 101, just like you said, a real practical approach, really geared towards team members especially, and as well as doctors. It's a great place to get started, and we have a lot of fun doing it. I think you're going to give my information at the end, and so I can give you a coupon code as well. So Raleigh and then in California.
Excellent. Yeah, and I've been to a few of those courses, and they're phenomenal courses. You always do a great job, of course, and anyone that's ever seen T-Bone speak knows that he's one of the most engaging, entertaining, no BS presenters out there, and you guys really do a great job, both solo and in tandem. So highly recommended course.
Good cop, bad cop. Oh,
Yeah.
Just real quick, it's August 17th, 18th, September 28th, 29th in California, and then November back in Raleigh. So 9th and 10th. Thank you.
Yep. And then you mentioned the symposium earlier. You spoke in both 2017 and 2018 down there in Clearwater, Florida. We're giving you a year off, but there's a list of speakers that we've got for February 2019. Jameson Spencer, Keith Thornton, the inventor of the TAP therapeutic protocol. Very
He's
glad.
entertaining.
Yeah, Dr. Thornton is entertaining. Yep, most of the people up here, if they ever wanted to quit their day job as dental sleep experts, they could certainly go and be professional entertainers. Ken Burley, John Tucker, Stacy Ochoa, Randy Curran, Guy Atros. I mean, really, it's a veritable who's who of dental sleep. But you've been there the last 2 years. You had a good time?
Oh my goodness, Florida is about the farthest place away from me that you can get, but so worth it. Like, first of all, Clearwater is now my favorite place in Florida.
It's on the beach.
And
the venue
it's right on the beach.
White Sands in February.
Yeah, it's perfect. But honestly, I'm all about the keep it simple, practical, like I said. The 1 hour lectures from some of the powerhouses is perfect. I love the interaction. It's not like, it's a big group, but it feels intimate, and the location is awesome. I think it's very well done, Jason.
Oh, thank you. And that's unfortunate. I'm sorry I didn't catch it. That discount code has expired. However, like I said, the venue is on the beach, and we have a discounted room block, and every year it sells out. People contact us all the time wondering why the rooms cost several $100s more than they anticipated, or wondering why they had to book up the street. So get registered now. Go to ds3sleep.com to get registered, and make sure you book your room. You can do it all there right through the website. And then also, for any of you that are on here that are DS3 members, thank you for being here. For those of you that aren't DS3 members, you can just type consult, and Jody or Brandy will circle back with you tomorrow. And they'll want to learn they'll want to learn about your practice. They'll want to learn about your goals. And then they'll talk about how we might be able to help you. Dr. Elliott, you mentioned a few things. You mentioned the benefits of a third-party medical biller. You mentioned correspondence with physicians. You mentioned proper documentation. And if I can put you on blast here, you're a DS3 member, so you manage most of those processes through DS3. And does that help hinder your progress?
Yes, I will easily give you a plug, because it is one of the best decisions we made just to keep it separate from EagleSoft. We only use EagleSoft or whatever dental software you have for the radiology and simple demographics, so we can schedule them. Everything, the ledger, the progress notes, everything's done through DS3. And I don't have the time to sit there with letters and create like a stock soap note and then plug it all in with each patient. I hope, and no one has time for that. And so I know what my time is worth. I know what a minute of my time is worth. And I don't want to spend any extra minutes doing something that a software can do for me. And like I said about the physicians, I keep them in the loop. I send letters. Medical insurance needs documentation, and it's all right there at the click of a button. And my team can get in, my third-party biller can get into the back office and grab what they need. And it gives my stay-at-home husband of almost 20 years a chance for a job to scan in all the images so we can be paperless.
DS3 is just trying to help you move towards a happy marriage.
He hasn't been a stay-at-home dad for 20 years.
Yeah.
Just to make that.
If you want to learn more about how that works, how that can work in your practice, how it can streamline processes, simplify this, whether you're working with a third-party biller like Pristine Medical Billing or 4-Pillar Billing, DS3 can really streamline a lot of those processes. So just type consult, and Jody or Brandy will circle back with you tomorrow and talk about how we might be able to help you. So type consult, and then I'll give the quick. That was my final Jeopardy music. We're back from the commercial break, and then the final clue is change management.
What is he? Oh, I know. I think I know. What is the real reason dentists fail at DSM?
Boom!
Am I right? Yes.
Confetti is falling. You win. You win. Real quick to that point, there's a ton of questions coming in. Please keep typing those in, and any that we don't address kind of with the prepared content, we'll hang out afterwards, Dr. Elliott and I, and make sure we get to all of those. So you're right. The final Jeopardy, #1 reason that dentists fail at dental sleep medicine. It's not medical billing. It's not side effects. It is change management. And it requires a new way of doing things. You mentioned earlier that dental billing is different than medical billing. Working with physicians, coordinating with physicians might be a little different than coordinating with other specialists, with a periodontist, with a prosthodontist. The records that you have to keep are different. What else is different? What else is a new way that that you have to do things to succeed in dental sleep? Any other new ways, new things you've got to adopt?
Oh, Jason, I'm not prepared. Give me an example.
Well, I mean, just there's medical billing, there's working with physicians, there's documenting properly.
Oh,
These are all
yeah.
things that you've got to do
Yeah.
differently in dental sleep versus restorative dentistry.
Oh, definitely. Yeah, when you get into the restorative dentistry mode, it's like that's what you know, that's what your comfort zone is. The nice part about a comfort zone is that it's comfortable, but nothing ever grows there. And you do have to think differently. The way I say it is that you have to put your handpiece down and put your stethoscope on. You should be looking at your patients through different lenses. You should not be able to unsee what you've learned. And even if you're referring to another dentist, that's fine, but talk to your patients about this. But yeah, there is, you know, we kind of don't use soap notes. We do now, but you kind of fall on old habits, and we totally do things differently now in a good way.
Got it. So one of the things that we're going to spend a few minutes on today is talking about an acronym that we put together, just go deep. And, you know, you can see in the image there, I mean, it's like an iceberg. It's like that root cause analysis. There's this surface level or above the surface issues. You know, frequently there are symptoms of that real problem. And we're just going to kind of share some insights, some tips that we've seen work in the most successful practices when it comes to implementing and growing dental sleep, treating more patients, growing production, and that means to go deep. So what does go deep mean? It means to generate. It means to map your objectives, to delegate appropriately, to execute, to evaluate, to pivot, and then keep repeating that cycle. So we're going to talk a little bit more about what it means to go deep. So the first one is generate. So you've got to generate your reason for doing this. You've got to generate your why, the meaning, the purpose of doing this, your motive. And this takes some introspection. So Dr. Elliott, I know that you're familiar with the concept of finding your why. If you don't mind sharing, what is your why?
What is my why? That is a theme that I use quite often, because if you lose sight of that, then the culture that you create in your practice will be lost too. And if you always keep that, your motivation and your why, the focus, and create a team around that, then they're not going to give up. They're not going to whine. They're not going to complain. My why is each and every, I shouldn't say each and every patient, but those patients that have been miserable for years and they didn't know it. I have testimonial after testimonial of, I had no idea how tired I was until I wasn't tired anymore. I didn't know what a good night's sleep was. Or I've struggled with this for years and my physicians kept putting me on sleeping pills. Or, you know, it's just all these things that we can connect the dots for the patients and that light bulb goes off. It's my favorite moment. My favorite moment is you literally can see them being awakened.
Mm-hmm. And again, that started with you. You opened them up to that. But then additionally, I mean, you had this vision then for how this was, why you were doing this. You had these goals. You mentioned the term culture. That's something that we'll talk about kind of throughout this next segment. But you crafted this vision. You had a why. You had a real reason for doing this. And you then believed in it, because I think that, you know, something I've seen amongst a lot of dentists, and my colleague, Dr. Yatros, talks about this a lot, is dentists that get out there and start trying to make this happen in the practice, and they encounter a hurdle or they encounter an obstacle. Things don't go exactly as they had anticipated, and they get discouraged and start to doubt themselves and doubt whether or not this is the right thing to do. And I think that having that belief that you're doing this, that you can make an impact, that what you're doing is the right thing, that it's the way to help people, is paramount. Agreed? Disagreed?
Agreed. At the root of it all comes down to the patient and knowing that you can help them and your team. I remember, actually, Jason, it was the course that I met you at down in Orange County.
I remember, yeah.
And
long time ago.
Yeah, this dentist said to me, he's like, yeah, I'm here. I heard, you know, a couple $1,000 for an effing piece of plastic. I'm in. I was like, oh my God, I hope you fail miserably, which you probably did, but
he might be on the webinar right now.
Probably not. It seemed a little too cool for that, but it's paramount that you always keep focus on the patient.
Yeah, so you keep focused.
Because I will refer for CPAPs if that's what is best for them. I won't make a dime on them, and that's okay. They are getting help that they weren't getting before. I think the average is 5 to 8 years that they go untreated, undiagnosed before even someone even mentions it to them. So if I can fast forward that for someone, I will do it all day long.
Sure. So you've got you've generated the vision, and now you've got these objectives. So it's one, I'm sure you've seen this. I've seen this ad nauseum, Dr. Elliott, where the dentist attends the course and goes back to the practice and says, hey, we're going to do this dental sleep thing. And whether they signed up with DS3, whether they signed up with, you know, our friends at OSAU, wherever it might be, they sign up with one of these companies, and then they don't share this vision with the team. They don't map the objectives. They don't give them a process for what this is going to look like. You've encountered that, not in your own practice, but you've seen it elsewhere, I'm sure.
Oh, no, I've seen it within my own practice, too.
I was trying to cover for you.
No, I don't want to portray that I have this perfect, you know, place. But to be honest, if my team didn't share that vision, they wouldn't be my team. It's that important. So if they didn't jump on board the way they did, then they just wouldn't be a part of it anymore.
But it falls on you to share that vision, right? To map those objectives.
Oh, yeah.
So for example, one of those courses I mentioned earlier, a dentist attends the course,
Mm-hmm.
signs up with DS3 because they say this looks like a great process to follow, a great tool to use, and then goes back to the practice and doesn't share with the team what that vision is, that we're going to help patients, we're going to potentially save some lives, we're going to get trained in use of this software, we're going to have a screening process. That's not just going to happen on its own. It's about communication. Fair?
Yes. And investing in your team to go to some of these things. You really do need to share the vision, but also even treating. If it changes their world, then how often will they share that with patients?
Sure. So you've generated the vision, you've shared the objectives, and now you have to delegate. So how often do you see where a dentist tries to manage all of these processes on their own?
I can't say that I know that number. However, I can tell you that the offices that go back and are the most successful at implementing are the ones that empower their team members. And that is, I cannot stress enough that is the biggest key.
Yeah, and at DS3, one thing we really stress is that a practice should identify, we refer to it as a dental sleep ambassador. I think you've got, you use the term dental sleep champion with Brie here. So can you talk a little bit about, who Brie is, what her role entails, and what she does for the practice?
Brie started out with me at a young age as a chairside assistant. Fortunately, she grew up along the way, but my former dental sleep champion was headed out on, she was going to stay home with her baby. And so I was like, oh crap, what do I do? Because, it was just like her and I for many years. That's why I said I can fast forward so many of the years of mistakes that I made, where I was like, oh, okay, they don't want to, hygienists don't want to learn it, or so the assistants say no. They don't really have a choice anymore. So, but saying that, I came to Brie and I said, hey, in 2 weeks, you're going to be my person. And she totally stepped up. It's someone who has organization, passion, customer service skills. She pretty much manages the whole thing. She's fantastic. And I'm still a large part of it, but I don't have to manage it. And she has so much ownership over it. And, you have to identify that person. It could be a diamond in the rough. And I would say that Brie was a diamond in the rough. It could be one of your all-star assistants that you dump everything on. You need to have a dedicated team member. Either you need to risk having your all-star chairside assistant take this on, or find that person that might be a wallflower but really can blossom. Or I've seen some offices use hygienists that are getting burnt out at being physically chairside and giving them an opportunity to do this. If you give them 6 months, it's an investment and may even be a gamble. If you give them 6 months and you're going to have to pretty much give a budget for that to pay them and to give them a chance to fly, but it will, if you can have someone that's dedicated to that. We're too busy doing bread and butter dentistry. But I'm not saying that Brie does it all. It's just that she can manage it. And I have a social media champion, I have an ortho champion, I have an implant champion.
Sure.
You got to delegate.
Yeah, it's so important. And I mean, I saw it in a practice in Florida. A dentist that for several years was treating 2 or 3 patients a month, and it just kind of plateaued there. And eventually, she hired a part-time dental sleep ambassador, and within a couple of weeks, that ambassador said, "This really needs to be a full-time job." Because it's an involved, it's a full-time position, and
Yep.
that dentist after bringing her on full time, I don't know, within 3-4 months, started treating 10 plus patients a month. You know, it's
Yeah, big difference.
huge difference.
And you know, if you have those if you have hygienists that are hesitant, like I always hear this, like, what if I don't know the answer? Well, you miss 100% of the shots you don't take. So you need to bring it up to the patient. Start the conversation. Bring Brie in because she's available. She's not chairside with an assistant. I mean, or a patient. She might be with a sleep patient, but bring her in. She can have the conversation. We always reschedule for a consult so we can sit down with that patient and really have a conversation. The hygienists need the chair. So we encourage, we actually schedule a separate consult so that we can really go into it. Dentists tend to talk too much and listen too little. So saying that, the hygiene chair is not always the place to have a conversation.
Gotcha. And with I want to be mindful of everyone's time. We've got the first E, which is execute. Just do it. You talked about this earlier. Make it happen. Analysis paralysis. You just got to do it, right?
Yep.
Start talking to patients. Start screening. Start treating some of the team members, some of their spouses or significant others. Any other steps that you would recommend for someone to just take some action and get some traction?
Oh gosh, nothing profound at this point, Jason.
It's getting late. So execute though. That's imperative. And then evaluate. So what's working, what's not working. Dr. Elliott, you've been doing this for a decade now. What's a process or something that you were doing previously in dental sleep that you've kind of evaluated how successful or unsuccessful it was, and then how you changed it?
When I first started out, I was like, oh, I'm not going to mess with medical billing. We'll just charge a fee and the patients can try to bill it themselves. And I did like all of 3. It's like I said, things are constantly changing. I think the most important thing that we have done is the champion. But saying that, anytime we talk to a patient, you have to find what their pain point is. Find their chief complaint. Find out what's motivating them. It's not always financial. Sometimes we put the barriers in our mind that we think the patients have. And so we really focus in on what's important to them and expound on that. Me going over the sleep study, and it's amazing because they're like, wow, no one's ever explained this to me before. Now all of a sudden they have ownership and urgency. Once they have urgency, they don't care how much it costs. They just want it. And all of a sudden they're like, oh, I need this yesterday. Mm-hmm. Even though they've had it for years and done nothing about it. So again, when I reevaluate things like, do we have the right systems? Are we missing, are patients getting lost in the shuffle? Are we doing proper follow-ups? I constantly meet with my financial gal and Brie. I bring it up to new team members. Like, there's just things that I'm constantly doing, keeping us ahead of the game. I go on webinars and forums and all sorts of things to stay on top of things.
Sure, gotcha. And then, so you evaluate, and what I just heard is you pivot. So you make a shift. You don't just, again, analysis paralysis, just review and find these issues. You actually correct your course appropriately. You mentioned earlier that you didn't always have a sleep ambassador. You didn't always have Brie. So you evaluated, identified these needs to change, and then you pivoted. Fair?
Yeah. I would say, because I have a partner, really, I didn't, when I had Brie kind of doing chairside and sleep, that was way too difficult. When I was able to hire on another chairside assistant and just give Brie, I said, you better make this work or you're out of a job. That was instrumental. So you're right, I do constantly have to pivot and reevaluate that.
Got it. So I would ask everyone on here if you can go deep. I mean, can you do this? Is this something that you can do to address these other issues with medical billing? Because all of those issues are symptoms of not going deep. So is this something you can do? And if you can, let's just make it happen. Execute.
Oh, yay.
Make it happen. And I know that we want to be mindful of time. We've already gone over. I apologize. It's my fault. I'm long-winded. But just real quick before we wrap up, and again, we'll stay on to answer some questions. There's some we didn't get to that we'll touch on if you can hang out. Again, you can type consult now, and Jody or Brandy will get in touch with you tomorrow. DS3 is not just a software. I mean, that's a big benefit that Dr. Elliott mentioned, but we provide discounts on continuing education. We put all practices through a training continuum where we really walk you through the processes, how to screen, test, treat, and bill, and maximize efficiency. Also, again, keep an eye out for your CE certificate via email in the next 24 hours. There will be a link to register for that next webinar. Be sure to join Dr. Yatros and Dr. Drake there. We have our own online magazine, the Dental Sleep Insider. This next issue, it comes out Tuesday, and it's focused on home sleep testing. Varying views from the profession as it relates to really a controversial topic, which is dentist involvement in dental sleep. So be sure that you visit dentalsleepinsider.com to register for that, or you can go to our new website, ds3sleep.com. You can subscribe to that. It's free. It'll take you 12 seconds to register, so go get that. Come to the symposium. You can register for that at ds3sleep.com as well. And then Dr. Elliott, there you are at the symposium last year. I've got your contact information up there. And I think that
it's important to remember with my contact, it's 2 L's, 2 T's, 2 D's. Erin Elliott DDS. 2 L's, 2 T's, 2 D's.
Yes, 2 L's, 2 T's, 2 D's. Dr. Erin Elliott. And again, you can just type consult. Jody or Brandy will get in touch with you tomorrow. We just want to help you. It's what we do. We help dentists implement dental sleep, boost their production, boost their efficiency. And then we've got some questions, Erin. So with everybody that's on here, if you've got to bail, we understand. Thank you all for being here. For those of you that want to stick around, Dr. Elliott, we've got a question from Dr. Link. He asked if you.
Hi, Tal.
Yeah, he asked if you schedule the consult from hygiene before trying to schedule the HST. He thinks that could work better for him. It seems like he's always rushed when talking with patients in hygiene.
It's always rushed. And when you all of a sudden you have a patient who hardly understands why they need a crown or what periodontal disease is, and then you're talking about this totally other concept, there's just not enough time. Plus, you need to talk about their dog and their summer vacation. So we do always reschedule for a consult, but that's just the way my practice runs. There's some areas, demographics, where time is of the essence, and if they walk out that door, they're not coming back. So I get that. But even moving them to a different room, even moving them to a consult room to have a further discussion. We collect medical insurance cards on the way in, but if in the past, again, this is another reevaluate and pivot thing that we've done, what I say to them is, you know, there's so much more to this that I'd love to share with you, and I'd like to hear more about you. So we're going to go ahead and schedule you for a consult so we can really sit down and discuss this more in depth. But the good news is that you may not have to wear a mask. You may not have to go spend the night somewhere. And we can bill your medical, not dental. We can bill your medical insurance, not dental. Your medical, not dental. I say it enough times. Then all of a sudden you eliminate the spending the night somewhere barrier, the CPAP barrier, and the money barrier. And they're like, oh, okay, I'd like to know more. So rescheduling them has worked well for us, and then patients don't get dropped. It's not rushed. You can create that urgency and value and connect the dots for patients. But that's not every practice. That's what works for us.
Gotcha. And what about, I had another question tangentially related to what we've discussed tonight, but what about home sleep tests post-device delivery? Do you always do one? And how do you manage that process?
Yes and no. So our kind of protocol is after delivery, we do a 1 to 2 week. It kind of depends on how confused they might have seemed, or, you know, if we had to make a lot of adjustments. For the most part, we don't need to. So we do a 1 to 2 week follow-up, a 1 month follow-up. If they're mild to moderate and doing good, then we'll do a home sleep test then. I do own home sleep test monitors for that purpose. However, if it's a referral from a sleep physician, this one sleep physician wants me to do it, another sleep physician wants to see the patient back to do it. And so it kind of always depends. Then I have some patients I'll refer back to the sleep physician, and he's like, oh, they're mild and they're doing fine. I don't need to do a follow-up. But I leave that up to the physician. Otherwise, in my process, everyone gets one after. When they're doing good, subjectively feeling better and quiet, we want to make an objective measurement of that.
Gotcha. Any other questions? I see, you know, we're fortunate that, I don't know, there's been dozens of questions, but we're fortunate we've got our team on here answering them in real time. So it looks like we might actually have them all covered.
I see. That's what I do have to admit. I was distracted earlier when you were asking me a question because I was reading some of them. And is the consult free? Is one that I see here. We used to advertise that, but we don't anymore. We will, when the patient comes in and moves forward with treatment, we do bill that to medical. Because if I advertised a free consult, I wouldn't be able to.
Gotcha.
So it's up to you and what works for you. But it worked well for us in the past, but now that we kind of bill everything through medical and most likely the deductible is going to be met, then we bill it.
Just had a question come through from my dental sleep BFF, Patty Burley, asking if you bill for HST.
No. I incorporate the follow-up as part of it.
Gotcha. And my friend Stanley Rauschweger is baiting us with questions, but there's some that it's probably best that I reply to him offline. They're inappropriate for this discussion. So any other questions? I think that's it. So everyone, thanks for being here. I'm sorry we ran long. Again, I tend to be long-winded. Patrick Tessier, I'll take that as a disrespect that I look like Dennis Hopper. And Dr. Elliott, seriously, thank you so much. It's been, you know, I'm so thankful to count you as a friend and to continue to learn from you, with you. And thanks for spending your night with all of us tonight. Thank you.
Yeah, thank you. I actually did not know the video was showing this whole time, but that's okay. Everyone can see my braces.
Lovely. All right, well, cool. Well, thank you.
Thanks, everybody.
Thank you. Bye-bye, everybody.